Next speaker is Dr. Nitin Balakrishnan, Medical Director, Head of Cataract and Refractive Surgery Services at Sai Deep Eye Clinic and Crystal Vision Laser Center. And he's going to have another teaching video for us. On to you, Dr. Nitin.
Thanks, Chitra. Thanks for the opportunity. I'll start with sharing my screen.
Yeah.
Thank you. So this was another routine day in the OT, end of almost coming to the end of the list. A routine grade 3 nucleus being chopped, and didn't think much about it and was continuing more on a remote mode, the phacoemulsification. Having done a good rhexis and having done the initial chops, so getting the fragments out when suddenly we noticed something which was not normal. There, if you can pay an attention over here, it's important that one pays a good attention, and when such a thing is noted, before coming out with your phaco probe, irrigation shouldn't be put off. Before coming out with your phaco probe, very important to inject viscoelastic. We then continue by putting in capsular hooks. Now, this was the first mistake here. On that particular day, we didn't have capsular hooks, so we had to make do with iris hooks, like you can see in this video. And having stabilized the bag with 5 iris hooks, there's another thing which I have learned over the period of time, that even though it's a small zonular dialysis, one needs to put in the hooks in the other direction, because there could be an overall zonular weakness. So this can extend if we just put in a capsular support in one quadrant. So we continue with the phacoemulsification now. Again, the next mistake over here, like you can see, is that the IOP was not reduced. We've kept the IOP at 46. On reviewing the video later, I realized that I should have had the IOP come down to a much lower level. Also, the aspiration rate should have been lowered. Luckily, it went well, but these things should be noted, and even the vacuum should be reduced in these cases. Treat these cases like a normal posterior polar cataract, where you have a low flow, low vacuum technique. So having removed the nucleus entirely, we now go to the cortical aspiration. So the third mistake here on review, that ideally I would have put in a CTR in this before removing the cortex, but I don't know what was happening. Probably at the end of the day that day, we went ahead and started doing the cortical aspiration. One way to justify that was, it is difficult to remove the cortex after putting in the CTR, but I don't think that's the right technique. One should put in the CTR before removing the cortex. Again, the gods were kind that day, and we managed to do a good cortical cleanup. And having done this, we are again reinflating the bag, and we'll continue by putting in a CTR here. So again, this, as you can see, is the fourth mistake here. The CTR is being injected in the side towards the area of the dehiscence. Ideally, a CTR should always be injected in the side away from the area of the dehiscence. So this was again a thing which was noted later, and this is now followed by putting in a single piece lens in the bag and doing a visco clearance. So the key take-home points here are that in all these cases of a zonular dehiscence, it's important to know that when it is occurring, to pay a proper attention and not to come out of the chamber unless the chamber is fully inflated. Keep the hydration on and inject viscoelastic before coming out. Thank you.
Yeah, wonderful teaching points, Dr. Nitin. But just supposing, like you said, no, like if your phaco parameters had not been brought down, so you could have hydrated the vitreous, and if the vitreous had to come out of the wound, there is a question to the expert panel too now. Would you advise an anterior vitrectomy in that area of vitreous if it were presenting at the area of the zonular weakness? Would you inject viscoat or push it back, or would you do a pars plana vitrectomy?
This is a perfect indication for a pars plana vitrectomy, Chitra.
Yeah.
Okay, I would just have an irrigation in the anterior chamber, put a trocar and cannula, and just put tricot in that area, viscoat in that area, and remove the vitreous from behind.
Yes.
So this is a perfect indication for pars plana vitrectomy. You were asking that question earlier.
Yes, yes. So basically, otherwise, I think he has told us all the very important tips about using a capsule hook and then placing a CTR. And of course, CTR could have been placed before the cortex removal.
True.
Otherwise, I think it was a very well done case and very beautifully showed. Anybody, Dr.
One trick about the CTR that, can I say?
Yes, yes, of course.
Yeah. So I think he was using Madhu Instruments preloaded CTR, I think, right? So if you don't have the right orientation CTR, just reverse it and put it inside. It basically goes from the other direction. So this has happened with me also, that I did not have the right direction. The only thing to disengage, you have to use the second instrument to disengage. So you just put it other way around, it goes from the other side.
Yeah.
So that
Very
works
nice
well.
point. Very nice.
Now, ideally, the CTR should have been injected, inserted through the side port, not with the injector, through the side port, because the rexis, which is normal, is on the left side for him. So the right side could be.
Yeah, that's,
otherwise, because inferiorly there was a zonal dialysis, if I'm right.
That's what I pointed out on review of the video. I realized that
I know you
right
mentioned
side of this thing, but I don't know. At the end of the day, certain things you realize only after you review the videos.
It was also a hypermetropic, I know.
Yeah, it was an hyperopic eye, mildly hyperopic.
Yeah.
Nitin, this is a testament to your skill. Despite a few things going wrong and reviewing data, you managed to do it very well.
Yeah.
So it's
One additional.
I
This faith in gods.
And also another thing I would like to mention here, Nitin, is that when you're using iris hooks, ideally capsular hooks, you mentioned that when using iris hooks, don't keep the traction for too long a time, and don't keep the traction for too much traction also, because they can tear the rexis.
Yes.
So if you tear the rexis, the whole battle is lost.
Yes.
So once you remove the nucleus, you can just relax the iris hooks a little. Yes.
Yes.
Just very well done, Nitin. One additional point is that the concept now is, and I have started doing it at least in these situations, shift to a 3-piece lens rather than a single-piece lens, and a 3-piece lens with the haptics going in the sulcus, and if you can create an optic capture, that's been very well shown that that stabilizes the bag extremely well, even in spite of the endocapsular ring already being there. Earlier, we used to put the 3-piece lens in the bag, have the haptics of the 3-piece in the area of the dialysis, that it adds as a additional support for the capsular bag. But now there have been enough studies which have shown that creating an optic capture with the haptics in the sulcus actually stabilizes these bags for a much longer time, much better.
Yeah.
Right.
So thanks a lot, Dr.
Very nice,
Nitin.
Nitin.
Yeah, very nice.